Good morning. Thank you for coming to the Geriatric Urinary Incontinence session. My name is Mary Palmer. I am a professor in the School of Nursing at the University of North Carolina, Chapel Hill. And on the podium with me today is Mandy, who is a professor in continence technology at the University of Southampton in the UK, and Dr. Adrian Wagg, who is a geriatrician and professor of healthy aging at the University of Alberta in Canada. Our disclosures are here. And our next slide, we're going to be talking about a geriatric case presentation today. We're going to have one patient that we will talk about, and we will be applying some of the geriatric principles that are used when we're dealing with geriatric urinary incontinence. This is not an exhaustive list of the geriatric principles, but it's more illustrative, and the ones that are in the pale blue are the ones that we're going to highlight in our case today. So we call continuity of care as we move through the case, bolstering the home and the family, of course communication skills, knowing the patient, very, very important in terms of what was the baseline measures like, what was the quality of life like before the person became a patient. Thorough assessment and evaluation, interprofessional collaboration, and you'll see that this morning as we move through the case, compassionate care, and helping disconnected family. So this is our case. This is Mrs. Kilby. We selected a person who had a hip fracture because of the significant morbidity and mortality that we know comes with hip fracture. Many patients do not resume to baseline functioning even after 12 months from their hip fracture. But we have an 86-year-old woman who's been discharged to a nursing home for rehabilitation after the surgical repair of her hip. Prior to her fall, she was living alone and independently in her own home. Her daughter wanted her to sell her house and move into an apartment closer to the daughter. On arrival, she was poorly mobile. She was having very little physiotherapy because of pain in her leg. She had an indwelling urinary catheter, and it was an unsupported leg bag. She was wearing a pull-up type of absorbent product to contain urine, although she had the Foley catheter. And she was also agitated at this time. She was confused, and she was calling out for her deceased husband. In the nursing and medical records, there was no history of prior urinary incontinence, but since the time of surgery, she was incontinent of urine and stool. There were no skin tears, but she did have a stage 2 sacral ulcer with no exudate. Now, from this point on, Adrian will be talking about the medical history, and then we'll move into assessment and the care plan for this lady. Adrian?
So Mrs. Kilby, prior to her fall and fracture, had some osteoarthritis which reduced her walking speed and ability to get out of a chair, but she was still independently functioning at home, as you'd heard. She suffered from mild chronic obstructive pulmonary disease, and largely that was untreated because she forgot. She has gastroesophageal reflux disease, which doesn't really cause her much in the way of symptoms, controlled hypertension, dyslipidemia, and in the past has had both cataracts extracted, with a reasonable result visually. Medication on admission to the rehabilitation home, acetaminophen, 900 milligrams, PRN, that's a Northern American dose, enalapril for her hypertension, 20 milligrams twice daily, tramadol, 100 milligrams twice daily, pantoprazole, 40 milligrams daily. The orthopedic surgeons had paid some attention to bone health and prescribed vitamin D, 1,000 units daily, and calcium, 500 milligrams daily. She was also taking a multivitamin, and the panacea for what was felt to be constipation, 2 Senna at night, along with 15 mils twice daily of lactulose. Mandy.
We thought the first thing that we should consider for Mrs. Kirby would be the catheter, because this will be if you like, the dominating issue in terms of continence management. So in order to get the brain cells working this morning, we thought we'd give some thought to what you might do about the catheter in this particular case. And these are some options that you might be considering for this kind of person. So firstly, keeping the catheter in until Mrs. Kilby acclimatises to the nursing facility and becomes more mobile. Keeping it in until the pressure ulcer has healed. Removing the catheter using absorbent products instead. Removing the catheter and using no products. Or ordering urodynamic testing and then deciding what to do about the catheter. So I thought we could do a bit of a show of hands at this point to see what people might think would be the best options while you sort of mull that over for a minute or two. So obviously she's got a pressure ulcer, and it is an indication, it's written in various guidelines, to use an indwelling catheter for use for, in some cases, in pressure ulcers. So what about keeping the catheter in until the pressure ulcer has healed? Who would opt for that option? You can put your hands up. Nobody? Okay. What about keeping it in until she acclimatises to the nursing facility and becomes more mobile? Right, a few people here. Yes, improved mobility seems a good plan. Removing the catheter and using absorbent products. Small number. Removing the catheter and using no products. Again, a small number. Ordering urodynamic testing and then deciding what to do. Just a few there. So I don't think we've got an overwhelming vote of confidence in anything in particular here. So it's worth thinking about what catheters do and why we might consider removing or not removing it. And I thought we could go through that a little bit just now. So in terms of the kind of problems that people have from using urinary catheters, we know that they're responsible for the majority of healthcare-associated urinary tract infections are associated with the use of indwelling catheters. We know that in acute care, up to 25% of patients receive a short-term catheter. So it would be very common to have a urinary catheter put in place if you're going to have hip surgery. So she would have had that put in possibly as a routine for that kind of surgery. We know that about a quarter of patients with an indwelling catheter for 2 to 10 days develop bacteriuria, bacteria in the urine. And after 1 month, almost all patients will have that. So we don't know how long she's had that catheter in for, but she almost inevitably will have some bacteria in her urine. And we know that 25% of patients with bacteria in their urine develop symptomatic urinary tract infection. So she might have, and she's agitated and confused, so it's possible that that's a symptom of that. And that a small proportion of those patients will develop bacteremia. In fact, that's the most common source of bacteremia in nursing home patients is urinary catheter. And also we know there's significantly high morbidity and mortality in catheterised patients. So there's a lot of bad news in having a urinary catheter in place, all related to urinary infection. And that's not even the half of the kind of problems that people can experience. So if we're looking at the risk-benefits of why should we keep that catheter in or take it out, it's worth thinking that through in terms of this particular patient. So I've sort of listed here why we might consider leaving it in and why we might consider taking it out. And I think it's interesting. I know this wasn't a particularly popular one, but it's very common to keep a catheter in because of a pressure ulcer. And it is a recommended practice in quite a few guidelines. However, there's a lot of disadvantage to doing that if it's a superficial ulcer. And in this case, it's a stage 2 ulcer. That's just the superficial top layers of the skin, the epidermis and the dermis are affected. There's no deeper damage there. You've got a problem with a catheter in terms of poor mobility. So there's no impetus to get up and go to the toilet. People often are much more immobile with a urinary catheter, and that, of course, increases your risk of worsening the pressure ulcer. The advantage, of course, of taking the catheter out would promote mobility and enable there to be a reduced risk of further damage to the pressure ulcer. Of course, if you leave it in, you've got the advantage that you're keeping the pressure ulcer completely dry. One of the problems with taking the catheter out will be contamination of the wound. So that's why I put here that it's worse or better for pressure ulcers if you leave it in, or worse or better if you take it out. So that's a tricky one to consider. But if you go back to the main problems, you've got inevitable urinary tract infection if you're keeping the catheter in. You've got a risk of bacteremia. You've got all the complications of having a catheter in situ. Risk of bladder, urethral trauma, which is agitated and confused, getting up, catching the leg bag in or the drainage bag on something and possibly falling, but also pulling the catheter out, so giving you trauma. Risk of falls, reduced dignity, having all that paraphernalia of catheters. Reduced mobility, I've already mentioned. And the main benefit being no urinary incontinence. But, of course, the catheter may leak. And in this case, she's already wearing an incontinence pad, so it probably is. So taking the catheter out has the great advantage of allowing for a continence assessment, which leaving the catheter in doesn't. But the risk is, of course, that she'll be have urinary incontinence, so we'll have to do something about that. There's a risk of falls with urinary incontinence. There's reduced dignity from being incontinent, but there is with catheters. And we've just already discussed the worse, better for pressure ulcers. But on balance, I would say that this is a catheter that should be removed. So it's probably going to be better for her. It's going to be definitely better for her mobility and probably improve her pressure ulcer rather than anything else, and will allow us to do a continence assessment. So, products or no products? Do we do pads or no pads? Well, of course, we don't know until we've taken the catheter out as to how severe the incontinence will be. So that's something to address to find out. And when thinking what kind of products to use and what you might consider, again, that depends on the severity of the incontinence and also how much fecal incontinence she's going to persistently have. I've shown here, generally speaking, patients prefer, and it would be better to have the smallest possible pad. I've shown a reusable pants there. If the fecal incontinence doesn't persist, then wearing a small pants with an integral absorbent gusset, a nice normal sort of underwear, enables her to go to the toilet, pull them down, take them up in a normal way. If we're talking about more severe incontinence when that catheter comes out, then you really need to consider the easiness with which she can actually go to the toilet and take down and pull up her incontinence pad, or take it off and put it on again. And in fact, the one up there, the pull-up pants, which she was wearing in the first place, are probably the best option in that regard, because they are most like normal underwear and easiest to manage. And it's all going to be about toileting for this person, so being able to do that will be very important. Things like diapers, very difficult to manage for anyone on their own, won't promote her self-management or being able to use the toilet regularly. So in the sort of heavier incontinence pads, it's going to be either the pull-up pants or possibly the pants with a pad in would be the easiest options there. So I think we'll move on now.
We've heard that she's come into the nursing home for rehabilitation. She's confused. She's calling out for her husband. So we think she might be delirious. Then why? And what might be the factors relating to that? And how do we assess that? And the most common method is something called the confusion assessment method. And this is essentially the list of criteria that one might use to assess whether she truly is delirious. So is there a history of an acute change in mental status? We've heard that she was certainly functionally able at home. We have limited details about her cognitive ability. We know that she was probably sensible. She was resisting her daughter's urging to move her somewhere else, so she probably was quite with it. But who knows? But the importance of a surrogate in terms of clinical history gathering becomes quite important. Is there inattention and fluctuating consciousness? And that becomes very important when diagnosing delirium. Is she disorientated? Well, we think she probably was. Is there evidence of perceptual disturbance? Well, she's calling out for her husband. Is there psychomotor retardation? That's really important because, of course, delirium generally can be split into two kind of categories, a hyperactive variety and the more worrying hypoactive variety with a higher morbidity and higher mortality. Because, of course, a quiet little old lady in the corner of a room doesn't really trouble any of the staff and doesn't really need anything doing. So you can concentrate your care somewhere else until you find her dead. And does she have a disturbed sleep-wake cycle? So what factors are operating in Mrs. Kilby's case? Well, there's the issue of pain. Pain from the arthritis, which is pre-existing, acute pain from the recent surgery. She may well have infection, both from a urinary source or perhaps from a contaminated ulcer. Possibly she hasn't been drinking enough, and that would be, the prevalence of dehydration in acute hospitals and in nursing home residents is quite high. Lack of mental stimulation, that's important, isn't it? And how much do we do for, or can we spend time and engage with Mrs. Kilby? She's in a new environment. If one goes to look at the delirium guidelines, and there's an example from NICE in the UK at the bottom of the slide, they often say that prevention of delirium is around a constant environment with a good day-night cycle, with constant relationships with staff, everything we can't provide in acute hospitals. Do we provide that in our nursing homes? I'll leave you to think about that one. So she's had a lack of sleep, she's had an acute illness, she's been in a busy ward environment. And of course then she's had an operation, so is she suffering from additional post-operative cognitive impairment? Well recognised, probably post-acute inflammatory response, which can cause cognitive change for up to a year later. So we need to think about these factors, manage them, and consider the extraneous factors. Can we provide a calming environment? Can we provide consistent nursing staff? Can we make sure there is some kind of rapport and mental stimulation? So we need to be aware of the current guidance on prevention, diagnosis and management of delirium. What about her pain? Well, she's receiving an as-required analgesic in the forms of acetaminophen. Is she going to ask for it? Likelihood is that's not the case. But then she's getting something, tramadol, an opiate medication, twice daily. It's not very good for older people in terms of their mental state. Has allegedly a less likelihood of causing constipation. But she's fecally incontinent, and she's been prescribed the usual concoction of senna and lactulose. What she really needs is a digital rectal examination. The likelihood is that she has overflow incontinence, and that needs to be dealt with. So what are the precepts that we would use here? Certainly the analgesic ladder. Start with regular simple analgesia and move up. Now, in terms of her acute pain, she may well be a candidate for a non-steroidal. She's got gastroesophageal reflux disease, but she's on a proton pump inhibitor, which may avoid any unanticipated complications of short-term use with food of something like ibuprofen. So we need to think about regular analgesia being the backstop, simple analgesia, and working up from there. She may well need a short-acting opiate for a certain amount of time. But that needs to be an appropriate dose, appropriate timing, and appropriate indication. So one of the hallmarks of a good geriatric medical care, again, would be a medication review. And there are some helpful criteria from both sides of the Atlantic which might aid us in looking at medications prescribed for older people and those that we might decide to discontinue. And those are the stop-start criteria and the recently updated Beers criteria from the American Geriatric Society. So it's a nice, handy, almost pocket guide for the Beers criteria, to which you can refer to try and reduce medications which might be complicating this lady's management. And she's far from uncommon. This is a typical picture of an inexorable decline of a previously well-functioning older adult into, well, having fractured her hip from a fall, she's 30% likely to be dead within a year. We're going to make that worse, unless we do something about it. So, Mary, what would we include in our assessment? So, regarding her incontinence, she might not have any lower urinary tract disease here. This may all be complicated because of her disease, but what would we do? We might want to do a validated continence assessment tool. It doesn't look very practical in this environment, does it, with this particular patient? But largely, something may be done. We'd want to do a urinalysis, a medication review. We'd need to at least assess her cognition and ability to communicate. We'd need to do the digital rectal examination. The old English adage, if you don't put your finger in it, you put your foot in it, is very common. No stranger to ICS. Is she got constipation? Has she got overflow incontinence? When we do get her sufficiently mobile, we need to do a toileting assessment covering her mobility, dexterity, visual discrimination. Can she manage her clothing? And what's her pain like? Can she manage? We'd certainly want to think about a continence and fluid chart in some form. All those can be very difficult to get and need to be dependent upon surrogates to finish them off and complete them. She needs some form of genital perianal skin observation and management of her pressure ulcer. And in terms of the ICI fifth ICI algorithm for incontinence of the frail elderly, that's all nicely encapsulated. Reversible causes of incontinence are all nicely encapsulated in the mnemonic DIPPERS. And I'll leave you to remember that one. So, Mary, what's going on?
With Mrs. Kilby, we have the physiotherapist working with the medical and nursing staff to manage the pain. She's starting to go to get sessions of physiotherapy, and she's becoming a little bit more mobile. The delirium is starting to lift, and now is the time the catheter is out to say, so what's going on with her incontinence? We need to ask about how many voids, in what amount, small, frequent episodes, and so forth. Does she have the ability to discern the sensation of the need to void? Is she able to communicate her need to go to the bathroom? And is she able to inhibit urination? All of these questions are very key to the kind of behavioral intervention that you will need to use. For someone who cannot inhibit urination or communicate the need to void, we would not put them on a prompted voiding or a bladder retraining program, but it would on a scheduled toileting kind of program. Again, what Adrian was saying, is there a urinary tract infection? Is there inflammation? The constipation again. The digital rectal exam is so very important and many times overlooked. And again, dehydration. Again, can she ask for fluids? Are fluids being offered to her? Cognitive status is so important. Delirium is considered a medical emergency, must be addressed immediately. But also, we're now starting to deal with the pain, and she's getting adequate pain relief. But we also need to be asking about sensory needs as well. Are her hearing aids in? Is her eyesight okay? Does she need to have glasses? All of these pieces are important. It's beyond the bladder, but it also helps with the functioning to get back to being a continent individual again. The trauma from the fall is a very important thing. Many times people totally focus on the hip and the surgical repair. Look for other injuries in other joints. Look for a head injury as well. Also, is she fearful of falling again? A lot was at stake for Mrs. Kilby. She lost her independence the day that she was wheeled into surgery, and she's at high risk of not returning to the life that she had once more. So a whole psychological process of fearfulness can be there as well. And again, can she get up and go? That is a very simple, straightforward test of mobility and balance evaluation. Will she be able to get herself to the bathroom? We know there's a high correlation between being independently mobile and being continent. We all know that a bladder record needs to be done for about 3 days to determine how many urinary incontinent episodes as well as continent episodes. What were the antecedents to the incontinent episode? What happened? Did somebody not come and help her? Could she not get up out of the chair? Did she not even know that she was incontinent and so forth? And we also get information about the fluid intake and as well as her bowel movements. Again, a bladder record is only as good as it's documented, and then the data on the bladder record is interpreted and used in the care plan. This slide is from some fairly old research. Snelly and his colleagues did some research about a decade ago. There is no reason to think that this is outdated. But they coined the term called reduced expectations. They found low levels of toileting assistance, 1.3 assists per day on average, too low to maintain continence. And they also found that nursing residents acclimated to that very quickly. They had low expectations of having toileting assistance. If Mrs. Kilby is going to become continent, she will need toilet assist, and she will need them at a level that will help her maintain her continence. So here's the preferred care plan for Mrs. Kilby. Safety precautions. We know that the strongest predictor of a fall is a previous fall, so she is at high risk for another fall. So we institute the safety precautions. promote cognitive functioning, engaging her in conversation about her bladder, about her physical functioning, so she's getting back into gear again about, I need to go to the bathroom, and asking for it. Improving her mobility so that she can safely get to the bathroom, transfer, and actually have adequate toilet access so that she can become continent. The behavioral interventions that may be necessary. She may not need a full prompted voiding intervention, but every now and then a prompt. Do you need to go to the bathroom? Do you need any assistance to go to the bathroom? The emotional support that she will need as she's in this transition is very, very important in terms of there was a psychological trauma as well as a physical trauma from that fall. And regaining independence means helping this person resume the self that she once was. Bolstering family and home. There will be home for her somewhere, making sure the family is connected, the friends are still connected. Again, that's what we call quality of life. It's the meaning of life. Everyone needs to have that. And so I'll turn over the summary to Mandy.
I suppose the main message here was this is somebody who was continent before she had her hip fractured, that she was going to get a catheter. She was, because she had her surgery, there were many aspects of this that could have been done, many things could have been considered to prevent her incontinence in the first place, which were perhaps not undertaken. And to consider that actually preventability and reversibility are the most important components here, that all these problems were most likely simply reversible or preventable, and that there was no evidence that there was any bladder problems here, and therefore we didn't need to consider much in the way of treatment. She may have had some residual incontinence, but we would expect this person to be completely continent at the end of her, over a period of time. So we had every expectation that we would have her being without a catheter and without a product at all at the end of her sort of management of continence programme. So this is perhaps a useful way of considering how we should consider continence: preventable, reversible, treatable, or manageable. But in this case, we were really looking at the first two areas. So I think it's... Oh, we've got time for one question, Mary tells me. So,
Hi.
Oh, hello.
I'm Peter Ozier from Utrecht, in the Netherlands. Without disputing everything that you have said, I fully agree with that. Adrian mentioned the tramadol in regard to some of the problems. But tramadol is a very well-known inhibitor of bladder filling sensation and a very well-known inhibitor of the initiation of voiding. And I think that post-void residual urine in this patient might play a role because of the tramadol. And I say it's very well known. It's very well. There's good evidence, but it's too less known. It's in the leaflet, but nobody seems to be aware of the importance of that. There is a subgroup of patients that's very sensible to these side effects. Many of the patients take tramadol have no effect at all, but some have a very strong inhibition of the initiation of voiding.
Oh, you're quite right, and thank you for pointing that out. We skimmed over it rather because of time, but certainly you're right. There are a subgroup of older people, notwithstanding the CNS depression and contribution to delirium, that do have that effect on lower urinary tract symptoms. And bizarrely, tramadol also useful in stroke in rats, but there we are.
And especially the residual urine causes a cascade of problems that you mentioned.
Yeah, absolutely. Thank you, Dr. Van Houten.
Yeah, I'm Paul van Houten from the Netherlands. I was curious, Mrs. Kilby get into the nursing home in the state she was.
Yes, I think we used a North American type model of short stay nursing home residence for rehabilitation, rather than the typical European "this is somewhere you're going to live" model. That's different. But you're right. She got into the nursing home in a rather unstable state. That would be unusual, but certainly not unheard of, largely because of bed pressures in the acute system.
Yes, because I should say, well, you start the rehabilitation before the operation.
Yes.
So it is a little bit startling that she get out of the hospital in the state as she was.
Absolutely, and in an ideal world, you're right, her discharge planning would have started with her appearing at the front door of the hospital. We see time and time again that process is deficient, largely because of the rapid pressures on, increasing pressures on bed turnover, which are motivated by emergency occupancy targets.
So there has been more geriatricians into the hospital?
That would be a good thing, we would say, yes. Okay. Thank you for your vote of confidence. Well, thank you very much for listening, everybody. It's time for the next session on behalf of the three of us. I hope you found it useful and educational. Wasn't what you were typically thinking about in terms of manage of LUTs in people with bladder disease, but it gives you an idea of the kind of world in which we operate, which is all additional to the usual content expertise we have. Thank you for listening.